Good afternoon, everyone, and good afternoon to the panel. You join me here live in the depths of the South Bank Centre during a absolutely fantastic social prescribing day, and it's great to see so many of you joining online as well. We're here today to talk about innovation in social prescribing, and we'll have a number of things we'll be discussing, but first I think it's time that we get to know our panel. So I think it'd be great if we could go around the room and we'll all introduce ourselves. So my name is Josh Ryan. I'm the head of Thriving Communities at the National Academy of Social Prescribing. Thriving Communities is a programme that supports social prescribing delivery organisations to network and achieve best practice in the sector. I'm going to go around the screen as I can see it, if that's okay, but can we now please go to Jeremy?
Good afternoon, everybody. My name is Jeremy Porteous. I run something called the Housing, Learning and Improvement Network. We are an independent network with over 20,000 professional stakeholders, predominantly championing good quality housing and care for older and disabled adults in the UK. Thanks, Josh.
Thank you so much, Jeremy. It's great to see you. Now, can we please go to Sue?
Hi, Josh. Thank you very much. I'm Sue Rogers. I'm head of practice here at Family Action. So we are a charity that have supported welfare of children and families, so cradle to grave for the last 153 years, and totally embedded in a social prescribing model of delivery. Good to be here.
Thanks very much, Sue. It's great to see you. And Tanya.
Hello, thanks, Josh. Hi, everyone. My name is Tanya Panuco. I'm a program manager at the English National Opera, and I've been specifically overseeing the program ENO Breathe, which is a breathing retraining program using singing for people who are affected by long COVID and specifically breathlessness.
Thanks very much, Tanya. Great to see you. Now, say hello to Alex.
Hi, I'm Alex Mazanovich. I'm a musician in the New Note Orchestra. We are a Brighton-based orchestra that supports people in addiction recovery and people who have been affected by drug and alcohol addiction.
Thanks very much, Alex. And Beth.
Hello, I'm also here from the English National Opera with Tanya from ENO Breathe. I'm the head of ENO Engage here, which is our learning and participation programme. So we thought it useful to have us both because it's both the programme and also how that connects into us as a company.
Brilliant. And last but by no means least, Layla.
Oh, am I unmuted? Yes, I am. Thank you, Josh. Hi, everybody. Great to be here. My name's Layla Shirar. I manage the social prescribing service at the Bromley by Bow Centre, which is a community centre based in East London.
Thank you so much. And thank you again to all of you for coming this afternoon. Now, we're going to kick things off, I think, by talking about health inequalities. We know that social prescribing is key in tackling health inequalities and reaching areas of most need. How do you feel that social prescribing and more importantly, the work that you do can be used to tackle such issues? I'm going to throw it open to the panel. Anyone would like to come in? Jeremy.
It's a really great opening question. I think as I introduced myself, I work in a housing setting, and health inequalities can be demonstrated at first hand where there's also poor housing. In fact, we have a large amount of housing in the UK that is in disrepair or in poor condition. And what that demonstrates is that the link between poor housing and ill health there's an inextricable link. But what social prescribing enables individuals and working with their local communities is to think about not just about the type of homes they want to live in, but also the communities they want to live in and how their well-being can be improved by making some simple adjustments to those homes, including tackling that chronic disrepair.
It's interesting, isn't it? The interventions can be as strong as they can be, but if you're going home to somewhere that is not fit for purpose, you're not going to have the knock-on impact. And when you say that, you know, you're advocating this kind of circular approach, it's what we in the Thriving Communities program are referring to as a whole community approach to social prescribing, which brings across people from multiple sectors having multiple interventions, but including things like, you know, money advice, which is something that so often gets ignored, but is absolutely crucial to people's well-being, and especially in kind of the current times in which we're living. I'd be interested to hear from any other members of the panel how you specifically are kind of approaching health inequalities, maybe how you're connecting with communities that traditionally don't connect so well into the health system through social prescribing. Sue.
Yeah, thank you, Josh. I think that you know, there are several elements on there that participate this health inequality. If we take this morning's debates, 4% of the budget is spent on children. You know, there's a health inequality from day one. And also there's the cultural deficit within social prescribing as well. So often we're not always thinking about the cultural requirements of people within that scope of work. And with many of the social prescribing elements being delivered through GP practices and linked through GP practices, what are we doing about communities that probably don't go to the GP and are the most isolated and maybe culturally deficit within that as well? So some of our work, we go out into the community. So we are the link provider from the PCN, but we don't naturally work wholly from the GP base. We go out to where the communities are. So we go to the faith-based groups, we go to the local communities sat within whole communities, and work collaboratively with them to facilitate change and make movement in positive steps.
I think that's really important, building those networks into underserved communities. And it's one thing that I like to think that kind of once you build a bridge and you build a network, it grows and it grows and it grows and it grows, and it becomes more powerful, and it brings on more partners, and we can utilize our capacity kind of more fully as a sector. I see Alex has your hand up.
Yeah, so the New Note Orchestra, and there were other addiction recovery arts organisations around the country. I think we're very much looking into this idea of, recently there's been a lot of discussion that community and having better social networks is a really good way of supporting people in recovery. And there's a lot of discussion around, like, addiction is actually like a failure of community for a lot of people. And so within organisations like the New Note Orchestra, we're trying to do really like two things around that. One is offering a new community that people can be part of, which is based around respect, but also based around action, and it's based around art, and it's based around expression. But it also helps people in addiction reconnect to their community in the form of performances, in the form of a lot of other work that we do.
It's interesting, Alex. So am I right in thinking that, you know, when a lot of people say community, they in their head kind of mean a locality, you know, a small area. You yourself, through your work, you're kind of building a community here.
Yeah, that's right. I think especially people in recovery, once they're out of the kind of initial health crisis mode of going through a rehab system or something like that, find it very useful to have a community of people who have got very similar lived experiences. Mm-hmm. And not just that, people who have been affected by addiction in other ways, maybe a family member or friend, mm-hmm, or somebody very close to them who have seen that. I think it's really important to offer a much more positive view of what recovery can mean. And I think part of that is by having a community of people who are, you know, essentially enjoying themselves and living life and being very productive and happy, essentially, in what they're doing. And I think it's very useful and important to offer that as a community. But I think it's also important for our locality. Like, New Note is building up a reputation in Brighton, and as being a group that offers kind of quality art, quality music. And I think that's really important to break down the kind of taboo and stigma around addiction, and bring people who have perhaps been at odds with the local community in previous times to then become part of that, and an important part of it.
That's interesting, like a kind of a reintegration process almost.
Yeah.
Yeah. Well, it's interesting, in like, obviously you do this through kind of harnessing the power of arts and culture. I'd be interested in hearing from the cohort from the ENO, like, what does the ENO kind of push in terms of its social prescribing offer through arts and culture? Because obviously you're a very large and you know, well-known organization, and it's great to see you in this space. Kind of what brought you here, and what is it you're doing?
Yeah, thank you. Yeah, it's really new to us. I think that COVID, as COVID happened, as a company, all of our sort of business as usual was not able to happen. Theatres closed, everything around the country closed, and we did do things like a drive-in opera slightly later, but before that we were thinking about how we could be useful in that time to society. The first thing that the organisation did was our costume team. So we have an in-house costume team at ENO here who create and sew all the costumes that you see on stage. Those staff were all put on furlough as COVID happened, but still wanted to be useful and really were at the spearhead of the sort of scrub sewing like endeavor. We were doing that directly for Imperial at the time, but we also felt like there were other parts of the company that could be being put to good use at that time. And that was when the chair of our board here at the ENO, Dr. Harry Brungers, connected us in to Dr. Sarah Elkin from Imperial, and we were considering what role singing could have and the breathing techniques that opera singers use to consider people with long COVID. At the very start, it was just an idea and a bit of a test and an assumption that we thought there might be something useful there. We brought together the clinicians from Imperial and the singers that we're working with at ENO to sort of meet and to connect and to think about what that overlap might be. I think something around inequalities that's really interesting to us is that of everyone that we're working with through ENO Breathe are people who have long COVID. Long COVID means very different things to lots of different people. The symptoms can be completely different, and how debilitating that can be to people's lives ranges hugely. ENO Breathe is for a particular subset of those people. So you have to be referred onto our programme by a long COVID clinic. So you do have to be accessing our support through having gained medical attention. In some places now we're finding that the desire to be on ENO Breathe is supporting people to then connect into their medical services, and we were super lucky with the amount of press attention that our project got at the time when I felt like there wasn't really much good news stories in the press, and I think we really hit that note of being something positive, and that's why it really sort of got the attention that it did. But I think it's been an interesting thing. We have lots of people emailing to say, how can I get onto this program? And then we signpost them towards their local long COVID clinic to sort of say, this is how you have to get there. Now, obviously that it's not for everyone. And we do have to say to some people that you don't meet the medical criteria, and we don't see everybody that might want to be on our program, but it is something that we are investigating, and I guess we're at quite an early stage of our journey into sort of in social prescribing, but we know that there's a demand for this work, and we feel like there's probably more that we can do outside of the existing program that we have. So it's sort of in our current work to explore where we might be able to use this learning that we've had through this program to start to think about that in slightly broader spaces, whether that's outside of long COVID and still thinking about breathing or lung function in individuals, but also in the more well-being space. It's been really interesting to sort of see, as participants have joined the program because they are struggling with their health, they sort of come through that, they gain the skills to sort of self-manage their condition, but as a little bit of a byproduct, they grow an interest in singing, in opera, and we're sort of interested now to see how can we pursue that and think about some other social prescribing links into our organisation that might be more straightforwardly like visits to our venue in groups, and sort of those more traditional social prescribing routes are sort of at our fingertips now that we're excited to sort of delve into.
It's fantastic to hear you sort of dipped your toe in the water and you're seeing such demand for your services. And it's interesting a point you raised about kind of not necessarily inappropriate referrals, but referrals into your program that maybe isn't quite the right fit. And it kind of brings me around to the crucial role of the link worker, you know, the absolute main cog in this system, directing people towards provisions and activities. And I was wondering if anyone had kind of any experience of their working kind of in new and interesting ways with link workers, and kind of what's happening out there at the moment. Sue.
Yeah, I was just answering in the chat actually. So we do deliver some of our social prescribing digitally. So those referrals may come through GP or through community-based other community-based assets and partners. And there is a choice programme, so we deliver blend. So those 6 to 8 initial sessions with a young person or an adult that's been referred into the service can opt into either digital-based support like this via Teams, or face-to-face or place-based. So I think that one of the things that COVID has done for us is it's enabled us to be more flexible in our approach and meet the needs of the client rather than having a one size fits all approach. So actually that blend is really good. We deliver parenting programs as well as part of our social prescribing, and we can deliver those all digitally, and we found that that's been a big asset. So we're very open to kind of offering that blend offer of what suits the person and being person based rather than being organizational led.
I'm a huge believer in there never being a one-size-fits-all model in social prescribing. And of course, we can talk, about the issues with digital exclusion, but being able to include things digitally gives you access to a whole wider audience, and not just locally, but nationally as well. And I think it's really important that organizations kind of take up that mantle when they can. But Layla, I see you have your hand up.
Yes, I was just going to follow on from what Sue was saying. I think COVID really taught us a lot in our social prescribing service in particular. We always knew that health inequalities existed, but of course those were hugely exacerbated during the pandemic. And I think for us as a team, we needed to think quite fast and quite creatively about how we would meet the needs of the local community, the growing demand, the higher numbers of caseloads that link workers were receiving, but not only the higher numbers, but the complexity at which people were presenting to social prescribers. And for us, one of our biggest inequalities was around the area of housing. And we decided to sort of work really closely. I mean, we're quite fortunate in the centre that we had already an existing social welfare team, a sort of debt management housing team that were already established in the centre. But what we did was train up a qualified advice link worker that could manage some of the sort of a spillage of sort of social welfare referrals that were coming into the service. And I think that made us really think about how we evolve the social prescriber link worker role and move more away from kind of like the generalist approach of, taking all referrals and seeing everybody, but actually providing some specialisms, specifically in the sort of biggest areas that we receive loads of referrals, and that being social welfare, energy advice, mental health, and things like that. And I think that's what it's taught us. And yeah, there's been a lot of learning, and I think it is a continuously learning journey. I think we're only 2 years into having recruited our advice social prescribing link worker. So yeah, there's lots and lots to learn, but I definitely think a way forward is by creating specialisms in the role.
I completely agree. I hosted a webinar about a month ago now with a financial advice link worker. And obviously with the unprecedented cost of living crisis at the moment, her capacity was nil, essentially, because it is so needed. We've spoken a lot about kind of how social prescribing kind of begins in the home. And there was a conversation I was having earlier with a colleague of mine where I was saying that I feel social prescribing needs to become kind of endemic in people. It needs to be something that just happens, something that we don't even think about as unusual, something that happens every day. And that starts from a young age. That starts with children and young people. So I wonder if the panel might like to speak a little about kind of what they're doing to help foster that in families and kind of offer that wider support to children and young people. So.
Yeah, so we're very committed to systemic family social prescribing. So we feel that there is, when we speak about, or when a lot of people have that image around children and young people social prescribing, you think adolescent, but actually it needs to start at cradle. So we have perinatal support, that works through a social prescribing type model that is all evidence-based, whole family systemic approaches, children and young people approaches. So meeting the need of the whole family, but through a social prescribing type model. And we're very keen to expand that and look at, again, where are the health inequalities for our young people that we could bridge some of that. So an example would be young people coming out of CAMS service that don't meet adult mental health services is an absolute cliff edge of care. But just to drop them from a very medicalized model into a GP IAPT model perhaps isn't quite enough for them. So what could we do in a social prescribing bridging model that embedded their learning from CAMS, what works well for them, and support them with life skills and support to wrap around that to transition them into adulthood in a much more protected way. We've also done some services in A&E departments. So the lottery funded us to deliver referral process through A&E, where children, families, adolescents were having multiple visits for kind of non-medical requirement or non-emergency medical issues. And that was really good, with some really good outcomes there, massive reduction in sort of what A&E were calling reoffenders, but they're those people that you see on a really regular basis. But really interested to get involved and do deliver services right from the cradle. So supporting new families, increasing confidence and competence of new parents, having a real social impact that from birth will have a difference for that child through a social prescribing community-based model.
Absolutely, and this feels like the perfect opportunity to plug NASP's next webinar, which is on social prescribing across the life force in a couple of weeks. So I hope to see you all there. You mentioned something really interesting there about you had a fantastic set of outcomes regarding what they were calling reoffenders. That is something I think the sector needs to be much better at sharing, because there's so much evidence out there that these interventions work, that it could play very well into a discussion we could have all afternoon, which is evidencing the need for social prescribing and thus the funding position that we find ourselves in. That's a completely different discussion, and I'm sure one we will be having for years on end. But I just thought I'd throw that in there, because we're all doing this work and we're all gathering evidence. And I think we need to find a more sort of robust way of sharing it. Anyway, that's me on my high horse. I see Jeremy has his hand up.
Yeah, you were asking a question really about how do we get social prescribing into our DNA. Mm-hmm. I think one of the things that, and as Layla highlighted, COVID has had a significant impact, not just around health inequalities, but poverty, demonstrating the amount of poverty that's out there, and that has a real big impact on exclusion and inclusion, as well as things like housing inequity. And I see Dan talked about the number of people on waiting lists. But one of the things I think social prescribing is, it's part of a continuum of how we can support citizens build up different ways of being more resilient. And that can be from a housing perspective around having more active voice in the way the landlord-tenant relationship operates. It could be around prevention, about preventing homelessness, for example. So again, I see that what you're describing, yes, we do need the evidence there. There's a lot of evidence out there already, but we need to join the dots so that those DNA molecules are all part of the whole.
Absolutely, and that's kind of the message that we're trying to portray through Thriving Communities, I suppose, is that together we are stronger, and together we are able to make such an unassailable case for the fact that this works. I've just noticed the time. So what I'd like to do before we sort of finish off is, if you'll indulge me, I'd like to go around the panel, and if you could give me kind of one takeaway on what you think the future of social prescribing looks like. Where do we go from here? I will take hands as you think this through very quickly. I'll say my part. I believe so strongly in the whole community approach to social prescribing, bringing together people cross-sectorally through community hubs, through community connections, and through shared investment. I think that is the model that we need to be moving towards, and it's the kind of the model that I'm certainly championing at a regional level. And you know, if you stay tuned with NASP and kind of keep an eye on what we're doing, I really hope that we're kind of bringing some innovative work to the forefront. I see Sue has a hand up.
Yeah, I would like to see the future to be an absolute cradle to grave opportunity at place, which is appropriately funded at full cost recovery, acknowledging the requirements of third sector to run these services to a very high standard, that are safe. And the beauty of the third sector is we have so much more to offer than just social prescribing. We instantly connect in to every other service that we have and that we're connected to, and we're already embedded in those communities. So hubs, definitely, Josh, I agree, but with a real fresh approach to the funding streams and the timelines and turnaround of funding.
It's what I often say is that volunteers aren't free, and the more people realize that, maybe the bigger chance we have of securing long-term sustainable core funding. Alex.
Yeah, I think it's an understanding that a lot of mental and physical health issues can be helped and supported with strong community programs, but it's also giving everybody within a community the opportunity to partake in community led artistic projects.
Fantastic, thank you so much. And Tanya.
Yeah, I think it was, so that future that you're mentioning is basically just to echo that point around sustainable funding and having funding that really joins up all those different sectors, whether it's community sector, art sector, the health sector. And I think that's one of the points at the moment with ENO Breathe that we're really feeling really strongly around how do we sustain that program by really having funding that comes from those different avenues. And then the other point is, which is something we've noticed as well with our ENO Breathe participants, is how much they can be amazing advocates once they've gone through a program that has really changed something for them, for their health, and to actually utilize perhaps more those voices of individuals who have experienced those social prescribing programs to be at the forefront of, you know, our messaging and what we say, and completely integrating them and their voices in how we're shaping that future as well.
And that's a really great point. I have a statistic in my head. The Thriving Communities Fund, which ran for a year last year, it served about 11,000 people in the end, but about 9 to 10% of those went on to volunteer for their local organisation or delivery partner, or otherwise work for them. So it's kind of it's like a stone rolling down a hill, and it's that momentum that you kind of have to keep going.
Absolutely, yeah.
Yeah, two really quick points. I know you said one, Josh, but one being, I think that recognising that the voluntary sector makes up a large number of the onward referrals that we make within social prescribing, so that prescription, and the voluntary sector being, you know, the most at risk in terms of the continuation, a lot of these really important activities and projects that we put on for social prescribing patients. So for me, one would be more support money into the voluntary sector so that we can continue delivering some of those key services. Some of that is already happening in places. I know in ICS in North East London, they've started something called the Community Chest, where they have around 400,000 K, I think, to spend on activities where we find unmet need within social prescribing. So I think more amazing, innovative projects like that. And then secondly, it's, you know, not associating social prescribing with the health system. I don't know whether I'm going to get slapped, but but it goes back to Sue's point. Not everyone is going to go to their GP and hear about social prescribing. They're not going to be able to access it like that. So how can we start to train other key frontline workers in the principles of social prescribing, personalized care, what matters to the individual, and start to get other frontline workers to start addressing those social determinants and not it just being social prescribers. That way, you know, somebody can go to their, I don't know, a local children's centre and have somebody that's delivering a social prescribing type approach, or their job coach could provide them with that same kind of approach, and not just having it be social prescribing link workers. That might be controversial, I don't know.
It's certainly not controversial in my mind. I think it's about empowering communities to connect to their own need, and you can't get that intelligence just through the health system. It needs to come from the ground up. That's my belief anyway. Maybe I'm being controversial, who knows. Jeremy has positioned himself, looking at the time, as the last speaker, so it's up to Jeremy now to bring us home.
That was not deliberate. I couldn't agree more with what Layla just saying about, it's not just about health, it is about the whole system. And for me, it's all about co-production. How can we co-produce with our communities a variety of different models to challenge the real individual needs, but also the wider community needs, whether that's singing well, eating well, sleeping well. We need to think about how we use both the social architecture, but also the physical architecture, so we can make the spaces available for groups to meet, for individuals to participate.
Absolutely perfect, sir. I could not have said it better myself. And by Jove, I appear to have brought us in on time. I'd like to thank all of the panel today. It's been a really interesting discussion. I genuinely wish we had a lot longer to talk this through. I hope everyone has a wonderful social prescribing day, and I will log off from NASP headquarters. Thank you so much for coming, and I'll see you all soon.